Okay. So what was your last class? I think we have discussed about planning, right?
Yes, sir.
Yeah. So today we'll start with the new topic because you people are not attending the clinicals, right? So some people have attended the pre-postings and some are still lagging the postings. So keeping it in mind, so today we'll be starting with your indices part. Okay, some of you know what is index, what is dental hygiene index or oral hygiene index. So likewise, we have many indices. So these indices will help in recording the patient oral health status and dental care status and periodontal status. So these indices will help in assessing their oral health status, okay, and the condition of the patient. Okay, so this will be helpful in your final years, and if possible, if you people come to the department after this period, so then we start with this indices recording. Okay, shall we start?
Yes, sir.
Yeah, fine. I think, is it visible?
Visual, sir.
Right, good. Right. So I'll just give you a brief description about the indices. Okay, we have a definition and we have objectives and we have ideal requisites and uses and advantages and disadvantages of indices. So that will be covered in 10 to 15 minutes. Followed by we'll be starting with the indices used for assessing the oral hygiene status. Okay, so for today's class we'll be seeing only these two parts. Right. So the indices used in dental epidemiology. This definition of epidemiology will be dealt in your final year because you have a separate chapter that will be dealing with this epidemiology. So we have a small definition given by Russell AL. So the basic definition which we follow in a routine clinical is, first one is the numerical value describing the relative status of a population on a graduated scale with definite upper and lower limits, which is designed to permit and facilitate comparison with other population classified by the same criteria and methods. So if you see the definition line by line, so it includes the numerical value and status of a population and the graduated scale and upper and lower limits. So if we join these four terms, so a single numerical number will describe the status of a population on a definite scale, which is having both upper and lower limits. Something like upper and lower limits is we have the higher value and the lower value. So whatever the score may be, it will be varying between these higher score and higher value and the lower value, and which is designed to permit and facilitate comparison with other population. So it helps in comparison with the other population who are classified with the same criteria and methods. So this is the basic definition of index. So once again, I am repeating the definition. It's a numerical value describing the relative status of a population on a graduated scale with definite upper and lower limits, which is designed to permit and facilitate comparison with other population classified by the same criteria and methods. So there are some objectives regarding these dental indices. So first objective is to increase understanding of the disease process and to discover population at high and low risk and to define the specific problem under investigation. So our main objectives of recording these indices are, first thing is to increase understanding of the disease process, and second thing is to discover population at high and low risk and to define the specific problem under investigation. So first of all, if a patient comes to your clinic or to our hospital, so we'll start just examining the patient. So followed by that, if you record like this tabulation, just wait a while. If a patient comes to your clinic and if you want to educate the patient and if you want to make the patient to understand his oral hygiene status or the health status, in such situations we can take the format of any indices regarding to his oral hygiene condition, whether it may be periodontal diseases or it may be a gingival conditions or it may be dental caries status or the oral hygiene status. So if you want to educate the patient, sir, sir or madam, you have this much of score, which is pretty poor. So you have to maintain your oral hygiene. Likewise, we can motivate the patient. So that one is one of the common thing we usually follow in the clinicals, right? The first thing is to increase understanding of the disease process, and second thing is to discover population at high and low risk and to define the specific problem under investigation. So if you are see, last time I have given an example that you are appointed as a medical officer, you want to do some plan program, so you'll frame some planning process. Likewise, if you want to investigate a disease in a group of population, consider like a periodontal disease or a dental caries or a oral cancer. So you want to know the situation or the number of people affected with the disease. So now you start the survey to find out the cases who are having this type of condition. Then according to that, according to your scoring criteria, you will record the pattern of disease in that particular person. So after some time or some days of collection of your data, then you will segregate the data who are having the high risk and who are in low risk. Likewise, so these indices help in investigation or survey procedures, and we can easily segregate the people who are at high and low risk. So these are the two objectives of dental indices. Next one is your ideal requisites. So for any indices or anything, we'll have some ideal requirements. So the first ideal requisites is clarity, simplicity, and objectivity. Something like we have simplicity, clarity, and objectivity. Next one is validity. Third one is reliability. Fourth one is quantifiability, and next one is your sensitivity and acceptability. So if you see the ideal requirements, we have simplicity, clarity, and objective. Then the title itself suggests us that it should be simple and it should be clearly understood and it should have some objective. So we have already dealt with the objectives. So for every disease and for every index, it should have some objectives and it should have some objectivity and it should be simple and it should be clearly understood by any person. Next one. So if you see that, it should be reasonably easy to remember and apply in your field investigations. Next one, it should be clear and unambiguous with mutually exclusive categories. And the second one is validity. So validity is nothing but it should be intended to measure what is intended to measure, so that it should correspond with the clinical status of disease under study at each point. So if you see this validity, so for every disease, there are some phases. So if you categorize the a particular disease, like we have advanced stage, like severe and chronic, acute. Likewise, we have some phases. So initial stages and advanced stages, or it's a final stage. Likewise, according to the stages, it should be able to measure in different conditions. Next, reliability. Reliability is virtually synonymous with the reproducibility. The ability of the same or different to interpret and use the index in the same way. Reliability, the other word is reproducibility. Something like if you examine the same patient for 100 times with the same index, okay, so that index should give the accurate results and the same result should be produced. Or if 10 members have screened the same patient with the same index, so that index should be able to give the same result for the people who have examined 10 times, right? So this is called reliability. Next one, so it should measure consistently at different times and get and under a variety of conditions. Next, quantifiability. So it should be amenable to statistical analysis so that the status of a group can be expressed by a number that corresponds to a relative position.
Is the
Any?
slides change a bit, let's see.
So I have not yet changed, madam.
Okay, sir.
Okay. So if you see the quantifiability, so it should be amenable to statistical analysis so that the status of a group can be expressed by a number that corresponds to a relative position on a scale from 0 to upper limit. So see, in medical research, okay, or in research, so whatever examination or whatever surveys or whatever practicals or whatever research we have performed, so it should be the results whatever we have obtained in that, or the whatever data we have achieved in that research, so that result should be statistically analyzed, then only it will be having some validity. Okay, then we can publish or we can generalize those results. So that is the need of statistics. Okay, that to medical statistics. Okay, so if you have screened almost 50,000 to 1 lakh population, okay, different population have different disease status. So if you see the status, and we can't place all the 1 lakh people on a single sheet. Okay, so it is difficult to place all the data on a particular data sheet. So in such situations, these statistics will give the accurate results, and it will categorize the people who are in risk, that means in low or high risk or different stages. It will categorize and it will give the final result. So that final result will be useful in publishing the research work. Okay, so this is about your quantifiability. Is your sensitivity. Sensitivity is something like, so whatever the indices we have given, it should be able to record the condition at any small shift. Something like, see, every disease have some phases, or it have some, every disease will have some clinical signs and symptoms. Likewise, if you see here, sensitivity is something like, it should be able to detect reasonably small shifts in either direction in the group condition. Okay, so if you consider gingivitis, so gingivitis have different stages, something like acute or chronic, or something like we have severe bleeding, and we have severe swelling of the gingiva. These are some general clinical signs of gingivitis based on the phases. But in some condition, if it is in initial stages, we can see only the bleeding on probing. Okay, we can't see the inflammation of gingiva. So whatever the indices we prefer to record the gingivitis, so it should be able to record all the clinical signs and symptoms of the particular disease. So that is called sensitivity. The indices should be able to detect the small shifts of a disease in either direction. It may be in a negative direction or in a positive direction. Okay, between the higher and lower scores. Next one is acceptability. Acceptability is nothing but the use of index should not be painful or demeaning to the subject. So that if it does not hurt any patient or any person during the examination or during screening procedures, so everybody will accept these indexes in the screening or the survey procedures. So these are your ideal requisites of an index. And next one is your purpose and use of an index. So for individual patient and for your community procedures or in research. So if you consider for individual patient, so consider that the patient has come to your clinic. So first point is to provide individual assessment to help a patient to recognize his oral problem. First point. Second thing is we can reveal the degree of effectiveness of present oral hygiene practices. See, the second point is, suppose if the patient has come to you previously and you have advised some toothbrush or technique or your toothpaste or some mouth rinse. Okay, again he has visited to a clinic after 15 or 20 days. Then again you will record the same indices after use of your advice. Okay, it may be a toothbrush or mouthwash or your toothpaste. Then definitely there, if the person is maintaining and using the procedure whatever you have advised, then definitely there will be a change in scores. So in such situations we can reveal the degree of effectiveness of a present oral hygiene practices. Third one is we can motivate the individual. And fourth point is we can evaluate the success of individual and professional treatment. And last point is we can provide a means for personal assessment. So this is for individual patient. In case of research, okay, we can determine the baseline data before experimental factors are introduced. For example, I have told you many examples, right? If you have discovered a mouthwash with your own formula, right? So before giving that mouthwash to the patient, okay, we'll start with the baseline data. Something like the baseline data is nothing but the raw data you have collected before the intervention of your product, right? That is your baseline data before experimental factors are introduced. Again, after introduction of your experimental product in the patient's lifestyle, then he or she starts using that product. Then definitely after 15 or 20 days, we can compare that result with the post experimental factor. Okay, so next one is your in to measure the effectiveness of specific agents for the prevention, control or treatment of oral condition. And next point is we can measure the effectiveness of mechanical devices for personal care. So the best example for mechanical devices are like we have various toothbrushes, okay, and we have various plaque control measures, right? And next one, in community health research. So it shows the prevalence and trends of incidence of a particular condition and provide baseline data to show existing dental health practices and to assess the needs of a community. And last one is to compare the effects of a community program and evaluate the results. So these are the uses of an index in individual patient, in research, and in community health. So if we classify the indices, we have various classifications. The first classification is based on the direction in which the scores can fluctuate. So if you see the direction, we have irreversible index and reversible index. So irreversible index is nothing but, say, the scores may change. Okay, so the index that measures the condition that will not change, so that is your irreversible index. And the reversible index is the index that measures the conditions that can be changed. So the examples are dental caries index. So we have a familiar index called DMFT index. So D for decay, M for missing, and F for filled component. So it's a combination of three components. Okay, so if you see that, if you have diagnosed a caries tooth, okay, so the treatment options are like either we have to extract the tooth or we have to restore the tooth with some filling material. So the scores doesn't change in this irreversible index, but the component score will be changing from D to filled part. Okay, so next one is reversible index. The examples are gingival index or the periodontal ligament indices. So gingivitis is a condition, right? So if you record the gingival index before the scaling procedure, so definitely we'll have some high score. After performing or after doing your scaling procedure, after some days or some duration, again if you record the same indices, definitely there will be decrease in the final score. So that is your reversible index. Next, so first one is your based on direction, next one is your based on extent to which areas of oral cavity are measured. So to what extent you measure the oral cavity, there is a second classification, that is for full mouth indices, and the second one is your simplified indices. So if you see the same full mouth indices, so in full mouth indices we have to include all the teeth present in your oral cavity or in patient's oral cavity. Whereas in simplified indices, there is no need to examine all the teeth or the tooth present in the patient's oral cavity. So first one is, so if you see the full mouth indices, the indices measure the patient's entire periodontium or entire dentition. So the example for full mouth indices are, first one is Russell's periodontal index, and second one is simplified index. So the indices measure only the only a representative representative sample of the dental apparatus. So examples are OHI, S. So OHI stands for Oral Hygiene Index and S stands for Simplified. So if you compare with the full mouth indices and simplified indices, so in full mouth index, we have to include or we have to examine all the teeth present in your oral cavity. Whereas in simplified indices, there is no need to screen or examine all the teeth, but in every quadrant, some teeth are specifically kept for your examination. So those two teeth are considered as index tooth. Okay, if you examine that particular tooth, it is sufficient. We can assess that particular status of a particular quadrant on a particular side. Okay, so this is about your simplified indices. Next one. The next third classification is according to the entity which they measure, like we have disease index, symptom index, treatment index. And under special categories, we have simple index and cumulative index. So if simple index, so the simple index is something like we have whether the condition is present or absent. So if gingivitis is present or absent, or dental caries is present or absent, based on the condition and the presence or absence, it is considered as simple index. Next one is cumulative index. Cumulative index will suggest you the past and present condition of a patient. Okay, so this is your first part. Okay, so the next part is your indices categorization. So the first category is the indices that are used for assessing your oral hygiene of an individual. So we have two indices we commonly use. First one is oral hygiene index simplified, and oral hygiene index is general one. So the same authors has given both the oral hygiene index and oral hygiene index simplified. So we'll see with the oral hygiene index. So this index was given by John C. Green and Jock R. Vermillion in the year 1960. So it is sensitive and it is a simple method for assessing group or individual oral hygiene in a quantitative manner. And it requires the user to make more decisions, and the examiner should spend more time in giving the decision. And the methodology is, it has two components. One is debris component and calculus component. Okay, so for giving the oral hygiene index, we have to measure both the debris and the calculus component. Okay, then we have to file up and we have to add sum the scores we attain from the debris index and calculus index, and finally we will get the total score. So based on that score, we have to give the interpretation of a particular condition. Right. So the patient's oral cavity is divided into 6 segments. So we have segment 1, segment 2, and third segment, fourth, fifth, and sixth. So in every segment, we have some particular tools. See, if you see the segment 1, so from bicuspids to your molars. Okay. So bicuspids are nothing but your premolar, first premolar, second premolar, first molar, second molar, and third molar. Okay, whereas in your second segment, so the tooth included in the second segment are from the canine to your canine. So 1-3 to 2-3. Whereas in segment 1, we will be demarcating from first premolar to your third molar. Okay, likewise, it will be followed to your third segment, and it will continue to your fourth segment, fifth, and sixth segment. So starting from third molar in the first quadrant to ending with your third molar in your fourth quadrant. Okay, so totally we'll have 6 segments. So what are the rules that are implemented in oral hygiene index? So first rule is we have to include only the fully erupted permanent teeth into the oral cavity. Second thing is third molars and incompletely erupted teeth are not scored. Okay, and the third point is the buccal and lingual debris scores are both taken on the tooth in a segment having the greatest surface area covered by debris. And the buccal and lingual calculus scores are both taken on the tooth in a segment having the greatest surface area covered by calculus. This is an examination method. So, I think many of you know what is debris and what is calculus. So there are some scoring criteria for every component. So whenever you are examining, you have to divide your tooth into see something like, so this is your full buccal surface, okay, and on contralateral side we have the lingual surface also. Here we have to divide the tooth into various sections or various segments. So this is your gingival third, and this is your middle third, and this is your incisal third or above tooth third. So always start from high score to low score, because if you start from high score to low score, there is a high chance of excluding the high score. So if the calculus or the debris is not covered in the third segment, so then you can exclude that part. Then we'll shift to the next score, that is your score 2. So if the calculus or debris has not reached above two-third and it is present below two-third, then you can give score 2. So this is about your score 2. Next one is your score 1. So if the debris or the calculus is confined to your one gingival third or your clavicular one third, then you can give score 0. So, and if there is no evidence of debris or no stains or no calculus, then you can directly give 0. So the advantage of scoring from excluding from high score to low score is, see, so whenever you are passing a probe from one surface, from here to here, one surface to inner surface, if you start from low score to high score, so whenever you are passing your probe from one surface to one surface, there is a chance of spreading this debris from one region to your next segment, or we can say something like score 0 to score 1 to score 2, and score 2 to score 3. So to avoid that mistake, so you start from recording excluding the high score to the low score, then you'll get the accurate values. So if you see the scoring criteria, we have 0, 1, 2, 3. So the score 0 stands for no debris or stain present. Okay, then if there is no evidence of debris or stain, then you can directly give 0. Second one, you have score 1. So the soft debris covering not more than one third of the tooth surface, or presence of extrinsic strains without other debris regardless of surface area covered. Okay, so then you have to give score 1. Then score 2. So the soft debris covering more than one third, that means here. So this is one third, and if the debris is covering more than one third and not exceeding the two third, then you can give directly score 2. The third one, the soft debris covering more than two third. So if you see the image here, see the score 3. So the soft debris is almost extended beyond the two third and almost reach the incisal third, then you can give directly score 3. So this is about your scoring criteria. Same will be followed to your degrees and calculus index. This is about your calculation or the examination sides. So you have one third, two third, and above two third.
సార్ స్లైడ్స్ చేంజ్ అవ్వట్లేదు సార్.
అందరికి అదే ప్రాబ్లం ఉందమ్మా.
ఎస్ సార్.
సి చేంజ్ అవ్వలేదు ఇప్పుడు.
ఆబ్జెక్టివ్స్ దగ్గరే ఉంది సార్ ఇంకా.
జస్ట్ వెయిట్ అవై. ఇప్పుడు is it visible now?
ఎస్ సార్.
Yes, sir.
చేంజ్ అవుతున్నాయమ్మా?
అవుతుంది సార్.
రైట్. ఓకే.
ఎస్
Yes,
సార్.
sir.
Right. So I think you have understood the scoring criteria, right? And the examination sites we have 0, 1, 2, and 3. So this is your at the gingival third, okay, and this is above one third and not extending beyond two third, and this is almost extending above your two third and almost near to your incisal and exposed tooth surfaces. Okay.
Yes, sir.
Right. So the same will be followed to your calculus index also. So if you see the scores, score 0, so no calculus is present on the tooth surface. And score 1, the supragingival calculus covering not more than one third of the exposed tooth surface. And score 2, the supragingival calculus covering more than one third but not more than two thirds of the exposed tooth surface, or the presence of individual flecks of some gingival calculus around the cervical portion of the tooth or both. And third one is the supragingival calculus covering more than two thirds of the exposed tooth surface, or a continuous heavy band of subgingival calculus around the cervical portion of the tooth or both. So these are the ideal signs of a or the formation of calculus on the tooth surface, or deposition of the calculus on the tooth surface or the exposed tooth surface. Based on that, we have to categorize their scores 0, 1, 2, 3. Right. So this is your calculation part. So whenever you are calculating the debris index, so we have to add all the upper and lower buccal scores plus the total of the upper and lower lingual scores by the number of segments scored. So usually the segments are 6 segments. So whatever the scores we have attained in while examining in that particular segment, we have to add all the scores. Then finally we have to take an average and we have to give the total score. So that's the same will be followed to your calculus index. And finally, the so we as I have advised that OHA is a component of two things. One is debris index and calculus index. So next one is your simplified oral hygiene index. Is it visible?
Yes, sir.
Right. So the same authors has given this index, okay, in the year 1964. So the main thing for introducing these indices is first, so they have rectified the drawbacks in OHA and they have modified in OHAS. Yes, okay. So oral hygiene index simplified. So after 4 years, the same authors have given the simplified thing of this oral hygiene index. So here we score only 6 tooth in the particular segment. So the number of tooth surfaces scored are 6 rather than 12. Whereas in case of this one, what we call oral hygiene index. So we'll examine both the buccal and lingual surface in a particular segment. Whereas in simplified part, we'll examine only the 6 surfaces, okay, among the 6 segments. Like, so if we consider the upper quadrant, we'll examine only the buccal and labial surface of the tooth. Whereas in case of lower, in case of fourth segment and the sixth segment, we'll examine the lingual surfaces. Whereas in case in the fifth segment, we'll examine the labial surface. So these are the surfaces that is sufficient for attaining the scores. And the method of selecting the surfaces to be scored and the scores which can be obtained are from two components, that is your debris index simplified and the calculus index simplified. So if you see the image, so this is your buccal surface, labial surface and buccal surface, whereas in the lower jaw we have lingual surface for both fourth
సార్
quadrant
మళ్ళీ
and
స్లైడ్ చేంజ్ అవ్వట్లేదు సార్.
ఆ ప్రాబ్లం అందరికీ ఉందా?
ఎవరికి చేంజ్ అవ్వట్లేదంట సార్.
Just wait. Now,
ఎస్ సార్.
right. Is it clearly visible or I have to enlarge it?
విజిబుల్ సార్.
Okay, fine. I think this Google Meet is not supporting the animations, it seems. Right. So if you see the image here, so the total oral cavity is given in one picture. We have upper jaw and the lower jaw. So in the upper jaw, just blindly just remember that in upper jaw we have to score only the buccal surfaces. Okay, so for molars we have to examine buccal surface, and we have incisor we have to screen only the labial surface, whereas the lower quadrant or the lower jaw we have to examine lingual surfaces but for both molars, whereas in case of anteriors we have to measure the labial surfaces, right? So this implies both for debris index simplified and calculus index simplified. So the major difference between the oral hygiene index and the oral hygiene simplified is, see, in case of oral hygiene index, we have to examine both surfaces, that means buccal surface and lingual surface in both the jaws in 6 segments. Whereas in oral hygiene index, we have to measure only the particular or the intended surfaces per the particular segment. That means if you examine that particular surface, it is enough. Okay. Whereas in case of oral hygiene index, we have to measure both the buccal surface and lingual surface. But in case of oral hygiene simplified, it is not required to examine both the buccal and lingual, right? Next. So the examination methods and scoring systems are, so the scoring will be same for both oral hygiene index and oral hygiene simplified. So this is your calculation part. So the calculation of index. So for debris component, we have to add the buccal total buccal score plus lingual total score by number of segments scored. And whereas for calculus index simplified, we have to follow the same formula. And finally, we have to add both the scores attained from DIS and the calculus index simplified, and the values will be ranging from 0 to 6. So if you see the individual part, the scores will be ranging from 0 to 3, and if you combine both the DIS and CIS, the scores will be ranging from 0 to 6. That means 3 plus 3 will have 6, and the final interpretation is good, fair, poor. So if the total score is varying from 0.0 to 1.2, then we can say that the patient oral hygiene is in good condition. Whereas if the total score is from 1.3 to 3, then the patient's condition is fair. And the last one is from 3.1 to 6, which is in poor condition. Likewise, we have to interpret the patient's oral hygiene status. So this is about your oral hygiene index and oral hygiene index simplified. So these indices are used to assess the oral hygiene status of an individual and in a community research programs. Next. So the uses are, first one is first studying of the epidemiology in periodontal diseases, and the standard companion of the periodontal index in the worldwide studies of the Interdepartmental Committee on Nutrition for National Defense. And third one is in evaluation of dental health education programs in public health programs or public school health programs, and evaluating the cleansing efficiency of toothbrushes, and to evaluate an individual's level of oral cleanliness, and to a more limited extent in clinical trials. And it is easy to use, quick, and a high level of reproducibility is possible. So these are the basic uses of oral hygiene index and oral hygiene index simplified. And I have missed one thing, that the instruments used are your mouth mirror and your number 23 explorer. So in commonly we call it as the shepherd's hook. Okay, right. Next one. So This one is not required for you. Right. So the next indices is plaque and debris index. So to measure your plaque levels and your debris levels in your oral cavity. So we have various indices. The first one is plaque index. Second one is Turkey Gilmore Glickman modification of Quigley-Heen plaque index. And third one is Schick and Nash modification of plaque criteria. And the fourth one is Navi plaque index. So these four indices will measure the plaque and debris levels. So this will be dealt in your next class, and again I'll give some indications and contraindications of the indices and the methodology. So this will be followed later. Next one. So the indices used for assessment of gingival diseases, sir. First one is to assess gingival inflammation. We have papillary marginal attachment index. Then we call it as PMA index and papillary marginal index. Third one is gingival index and modified gingival index. And next part is use the indices used for assessment of gingival bleeding. So we have circular bleeding index, papillary bleeding index, gingival bleeding index, and fourth one is modified circular bleeding index and Eastman interdental bleeding index. So these are the commonly used indices for recording the gingival diseases or gingival status. So one is for gingival inflammation and one is for gingival bleeding. And we have some indices to record the periodontal diseases. Right. So first one is we have periodontal index for periodontal diseases and periodontal disease index, gingival periodontal index, and the community periodontal index of treatment needs. We commonly say it as CPITN index. And we have some indices to measure the dental caries. I just use the names. From next class onwards, we will see the individual part. So there are various indices that are used for assessment of dental caries. So the first one is decayed missing filled teeth index. So we commonly refer it as DMFT index. And next index is DMFS. So decayed missing filled tooth surfaces. And third one is caries index for primary dentition and the dental caries severity classification scale. And fifth one is your Stones index and Carey severity index and Czechoslovakian caries index, and you have Carey susceptibility index and modified DMFT index and dental caries severity index for primary teeth. So these are the commonly used indices for different conditions. And here are some recent developments in caries indices. First one is oral health status index and tissue health index, dental health index, and significant caries index. And different criteria for diagnosing pit and fused caries are first one is Anglo-Saxon system and European systems. So this is for your caries assessment. I think for today this is enough. Okay. So if you have textbooks, just go through those both indices and ideal requisites, ceremonies, objectives, and classification, and your definition part. Fine. And we have another index called the fluorosis index. So this you know what is fluorosis, right? So to assess the level, the severity of fluorosis, we have various fluorosis indexes. Among them, the popular one is the Dean's fluorosis index, and we have CFI, that is community fluorosis index. And third one is Thilstroff and Fajasco index for fluorosis, and the fluorosis risk index, and Young's classification of enamel fluorosis, and Murray and Shah's classification of enamel fluorosis, and the simplified fluoride modeling index. That's it. So for today's, we'll end up with this introduction part. And this is not required at your level. Okay, so indices for orthodontic treatment needs or for indices used for malocclusion. Just I'll give you the names. Okay, so index of orthodontic treatment needs. So only this is the only one that will suggest you the malocclusion status. That's it. Okay, so in the next class we will see about the gingival status indices. Okay,
Yes, sir.
right. So will you give your attendance, please?
Sir, respond to your roll calls. Roll number 1, 2, 3,
Present.
4,
Present.
5,
Present.
6,
Present.
7,
Present.
8, number 8, 9,
Present.
10,
Present.
11,
Present.
12,
Present.
13,
Present.
13. Okay, 14,
Present.
15,
Present.
16,
Present.
17,
Present.
18,
Present.
19,
Present.
20, 20, 21,
Present. 21.
22,
Present.
22.
22. Present.
Okay, 23,
Present.
24, 25,
Present.
26,
Present.
27,
Present.
28,
Present.
29,
Present.
30,
Present.
31,
Present.
32,
Present.
33,
Present.
34,
Present.
35,
Present.
36, 36, 37,
Present.
38, 38, 39,
Present.
40,
Present.
41,
Present.
42,
Present.
43, 44,
Present.
45,
Present.
46,
Present.
47,
Present.
48,
Present.
49, 49, 50, 50, 51,
Present.
52,
Present.
53,
Present.
54,
Present.
55, 55, 56,
Present.
57,
Present.
58,
Present.
59,
Present.
60,
Present.
61,
Present.
62, 63,
Present.
64, 64,
64.
six,
Present.
okay, 65,
Present.
67,
Present.
68, 69, 70, 71,
Present.
72,
Present.
73, 74,
Present.
75,
Present.
76, 77,
Present.
78, 79, 80,
Present.
81, 82,
Present.
83.
Present.
Absent is 1, 2, 20, 43, 49, 55, 70 and 73. Sir, that's it, sir.
Okay. Any doubts?
No, sir.
Right.
Thank you, sir.
Okay then. Thank you.